today's event. And for those of you that would like to listen to the recording, you'll receive a link, and on that link it will be to YouTube, I believe it is, and then you'll be able to play back the recording. Obviously, during the recording, we're going to be making comments and questions, and if you're listening to the recording, if you have a question, you'll need to email myself, Jeff at DDME or Jamison R. Spencer at gmail.com if your question is for him, if you're listening to the recording. The myth of protecting dentition. So today we're going to talk about three broad categories. One, can a dysfunctional airway create excessive headwinds in your protective, therapeutic, or restorative goals? It's a very broad question, and it's almost a rhetorical question, but it's a perspective that we're going to talk about today that is relatively new, and in light of now that we're measuring the interaction between the airway and parafunction, I think it's safe to say that there are some safeguards and planning that we can do based on this new information that we're able to garner. Another question that you need to know is tooth wear historical or is it ongoing? And it's a very important question when you're planning your rehab. And I think best way to think about that one is when you are starting, is there an environment in the patient's mouth that's going to create problems for you that you don't know about? And so we're going to talk about some of those problems that we've noticed. Okay. And the third item is when you look at your patients, is what your patient reports consistent with what you see? And you know, my background is in sleep, and I've developed sleep diagnostic instruments, and so I know already that sleep is a tricky thing to ask the person that you're treating because they're asleep. And it sounds silly to say, but when we're talking about asking a patient questions about their sleep, this really does need to be central in your mind, and they will tell you what they know. But again, really, there's no direct reports. They have to kind of rely on their bed partners or people that have heard or seen some of the behaviors that we often ask about. So the point of the third bullet is in dentistry, as in sleep disorders and in the sleep lab, there's extensive questioning that goes on, as there should be in the dental practice. And in those questions, we get the idea of what the patient's perception is of what their sleep. And where dentists can relate to this is when you talk to patients about tooth wear. And there's obvious wear, there's clear that at some point or maybe currently there's bruxism going on, and you talk to your patient about that and they'll say, no, I don't clench or grind, so I don't know how that tooth wear happened. It must, they're kind of at a disadvantage to answer questions about that. So we're gonna talk a little bit about that as well. Okay, when you're starting a case, and in the case, and it's pretty much applicable to restorations, orthodontics, any type of rehab, perhaps implants, is you really should know the environment in which you're going to be working. And the part that we're talking specifically is when the patient sleeps. And so we're all, very good at determining what happens and how the teeth look and function and so on and so forth. Where we're not so good is what's going on with the teeth when the patients sleep. So these are some questions that should be asked, especially when in light of some of the work that you're going to be doing. Is one, does your patient snore? Two, does your patient have oxygen desaturations? And that's pretty common in dentistry. Many dentists own oximeters, and oximeters have a place in dentistry, don't get me wrong, but we'll talk more about that a little bit later. And then is your patient clenching and grinding? And so when you answer or know the answer to these three questions, you're in a much better position to plan whatever treatment therapeutic options that you're going to offer your patients. Because all of these issues, snoring, oxygen desaturations, and clenching and grinding, have the potential to create a very hostile environment to the work that you're planning. So if you are aware of the hostile environment, and by that I mean, well, I'll tell you what I mean in just a little bit. But it's important, and it will help you if you know what it is that we're talking about. Okay, let's see here. There's a question. Okay, let's see here. Your audio doesn't seem to be working. Sorry, guys. Okay. If you can mute yourself, especially if you have a dog. Okay, thank you for saying that. Now we can hear. Okay, good. All right. The airway. So the three questions I just asked you about are all related to the function of the patient's airway. And as dentists, it's not really intuitive. I shouldn't say that, but it's relatively new in dentistry to take into account the function of the patient's airway. Okay, but it's very important because in some patients it's a big problem, and we'll talk about what that problem looks like and what can be done and maybe what shouldn't be done to manage it. So the issue that we're talking about, in the name that I've kind of tied to this, is airway triggered parafunction syndrome. Okay, you know, just giving you a little story and history behind that. I just used to use the word bruxism, and bruxism would describe what I'm going to be showing you in a minute or two. And in reality, you know, in many people's view, bruxism has a specific definition for a specific condition. And in light of, you know, relatively new information, airway triggered parafunction is different from that. Okay, so today we're going to be talking about airway triggered parafunction. And some people will call that bruxism. I will not enter that debate with you. You know, to me, I'm just going to describe to you what I've seen over the years. So first things first, this occurs during sleep in patients that have this condition. Number two, it's associated with airway resistance, snoring, or frank sleep apnea. And I will tell you, based on my observation, the more subtle the airway issue, the more likely it is to trigger parafunction. Okay, and in talking with people, stepping back for a second, when I first started measuring bruxism during sleep, there was, I went to some university, I went to some dental schools, and I said, look, here's what I'm seeing, and several of the schools called what I'm describing to you now central nervous system response. And I thought that was a great way to describe it. Unfortunately, a lot of the people that I talked to, when they labeled what I'm describing as airway or central nervous system response, they were kind of relinquishing responsibility of it, saying, well, that's a central nervous system issue. And a lot of times they wouldn't buy into some of the topics that I'm going to talk to you now. I think there's, in my view, we're talking about the same thing. Central nervous system response is the same thing as airway triggered parafunction, okay? And the part that we are most concerned about is the EMG activation, but there's more to it. So when the body detects an airway issue, and it can be a very subtle airway issue, it will trigger a series of events to restore the airway. The heart rate goes up, the blood pressure goes up. Typically there's an EEG arousal, and there's EMG activation. And we see that some in limb movements. Clearly as dentists we're not focused on limb movements, but it does show up there in the same way that it shows up in parafunction as measured at the masseter. So EMG activation is essentially what we're talking about as the component of the central nervous system response that affects dentistry. Okay? All right, I'm going to see if there's questions here real quick. Let's see, it looks like Stan might have one. Okay, that's good. Answered that question. Yeah, let's see here. Looks like Marty's got a question. Okay, I think I took care of that. Okay, next slide. So what I'm showing you now is an image, and this is 2 minutes of sleep from the Knox T3 home sleep recording device. And we'll talk a little bit about that in a second. But what I want to show you is what a regular clench, and this is what I would call bruxism, and this is an event that occurred. There's no trigger here, at least that we can see, and the masseter spontaneously fires in a big way. And let me explain to you what we're looking at. And I really don't want anybody to feel intimidated by all the squiggly lines. I just want to kind of show you a picture of what goes on, because a picture, as the saying goes, is worth 1,000 words. And I think you'll appreciate just seeing these pictures and what's going on while patients sleep. Okay, so you look at this, and this is all the respiratory channels, and this is completely normal breathing. And this is a patient that's sleeping well, and then they had a huge clench, and so you can get a sense of how big this clench is. If you'll notice, if you look carefully, there's two red lines here and here, and those red lines are set at about the max pressure that an individual could do if you ask them to bite down as hard as they can. On average, a person can generate about 100 microvolts worth of pressure on their teeth if you ask them to bite down as hard as you can. Those red lines are set at 100 microvolts, and you can see that this clench goes well beyond that. And when we first started using the Knox T3, 10 years ago, it was surprising how much stronger clenching goes on at night when a patient sleeps as when they're, during the day. And so there's a mechanism that's different, and whatever, the mechanism is, that when you're awake, it's, there's pain comes into it, discomfort, and then you relinquish the voluntary pressure. When you're asleep, that feedback loop is suspended during sleep, and we all know, everybody on this call knows, that the forces that the masseter can exert is just extravagant. It's really quite an elegant muscle because of the forces that it can exert. And at night when you're asleep, and that mechanism to ease off is suspended, your masseter brings to bear its full potential on the enamel, and this is one of the things that we see time and time again. Okay. Here on this slide, what we're looking at here is a grind. Okay, so clench, I'll define the events here at the end, but a grind is essentially, you guys know what it is. It's a lot more lateral movement. It's when you wear the teeth, kind of the cow's teeth kind of thing. It's a much longer event. Clenches, I think the max length is 2 or 2.5 seconds, and grinding kind of picks up where that's left off. And you can see clearly here on the masseter channels, that top channel where I'm moving the cursor there, you can see that this looks like it's an 8 or 10, and this is probably closer to a 15-second event. Now, the other thing you might notice is that the magnitude or the amplitude or the strength of the grind is a little bit less, but it's a lot longer event. So, you really can't say which one's worse, a clench or a grind. They're just different, and they both wreak havoc on dentition. Okay. I'm going to pause here for a second, and let's see here. And, okay. All right, airway triggered parafunction. So this is the first two slides that I just showed you were related to just kind of so you can get a feel for what a clench and a grind looks like, which I call a parafunction. And what I want to start kind of adding to these slides is these triggering events. Okay, so in this slide, there is a series of flow-limited breaths. So if you see where my cursor's going, there's a bunch of little orange squares on each of those breaths. So those little squiggly lines, those are actually from a cannula, and that's the patient inhaling and exhaling. Okay, and the software that we use in the Knox T3 allows us to detect flow-limited breaths. And flow-limited breaths are very, very important to be able to detect, and I'll tell you why. They trigger as much parafunction as anything else that we see. All right, so A lot of times when we talk about the airway, it's easy to say, well, let's talk about apneas and hypopneas, and those are very worthy topics. The more subtle airway issues are more likely to trigger a parafunctional event. In this case, it looks like there's a big clench there right at the end, you can see. And there's many samples where we'll see a bunch of flow limited breaths, there'll be a big clench, and then the airway is restored to normal functioning, and those orange squares aren't scored anymore because the patient's breathing normally and the system worked. Okay, but these are very subtle events, and I can tell you that there's very few devices that can detect it. And so if you're going to make a decision at some point to measure these, or maybe you're already measuring your patient, just if you're looking at a device, just see if that device can detect flow limited breathing, because in dentistry it's very important to know what the trigger is, because it gives you options when you know what the problem is as to how you manage it. Okay? Okay, here's a slide. This slide's pretty straightforward. This is the patient's breathing. They're breathing normally, and then here's the flow where my cursor is moving, and you can see the flow stops. All right? So there's a couple things to know about this. This is called an obstructive apnea, and it's the most common type of airway issue that we've measured through the years of doing sleep studies. Is an obstructive apnea. They're easy to detect, they're easy to treat, and so for those reasons, we count them, we measure them, and do all kinds of great things. On the medical side of things, I'm going to kind of jump tracks for just a second. On the medical side of things, we really didn't concern ourselves with bruxism, and the reason being is it's a dental issue. And just like for years and years and years, dentists really didn't take into account the airway. We had to, as dentists, we had to deal with parafunction and bruxism because of the havoc it wreaks on your patients. And the triggers for those reasons, the medical side wasn't looking at bruxism, the dental side wasn't looking at the respiration, and there was kind of a disconnect, and it created kind of a difficult scenario. Because you can see clearly here, and I'll show you, I think it's the next slide, this is very repetitive. Apnea, clench, apnea, clench, apnea, clench, and you see hundreds of these throughout the night. And some of the debates that we've had over the years would be, well, that's not bruxism, so I'm really not, that's not in my purview to deal with that. And I certainly respect that view because it's very valid. And the only thing that I ever say about that is that the enamel really doesn't care what caused the parafunction. It's pressure on the teeth. So there's, at the end of the day, there's a problem that has its foot in dental and medical. And so for the medical side, I can tell you guys, physicians aren't ever going to venture into bruxism. We don't ever have to worry about that. However, on the dental side, if you want to manage some of these triggers, you need to know what the triggers are. And the triggers are often some type of airway issue. So dentists, you're not going to have the same luxury that the physicians have because the physicians have kind of relinquished responsibility for bruxism to dentists as they should. Okay, yeah, this is the slide I was talking about. So on this slide, this is a 4 minutes of sleep, and let me kind of describe to you what you're looking at. And we're going to, and I just want you to note, so these boxes that you see, the blue boxes here, and then the beige boxes, those are obstructive apneas. The blue boxes are hypopneas. Hypopnea, by the way, just real quick, is a reduction in flow to 30% reduction in flow, and there's a few other things that happen in concert with that, and then we score it as a hypopnea. There's a 3% DSAT. If you're doing a full sleep study, you can look at the EEG, and if there's an EEG arousal, you can count it. So, hypopneas are partial reduction in the flow, and an obstructive apnea is a complete occlusion or nearly complete occlusion of flow. Okay, but if you look at this and you look at this patient and you look at each event, you know, and as I move my cursor and there are arrows there, you can see that almost every one of these has a little bit of a parafunction, and these would probably be counted as bursts and not really a clench or a grind. But then from time to time, you'll see the masseter says, well, I think I'm just going to go berserk on this one, and it fires. And then again, you see a series of kind of EMG bursts, which we care about, but because of the strength of the burst, a lot of times bursts don't have tooth contact. And for that reason, we're not able to generate a force that we're really concerned about because the teeth aren't touching. And if you've ever kind of measured yourself clenching or grinding or biting down, if you ever have the chance, I challenge you to try to develop a big, strong clench without tooth contact or biting into something. You'll see that it's really easy to tell when there's tooth contact. And you can see here, we know of at least 3 times there's tooth contact on this page alone. And the point of this, and what I get a lot, what I get a lot from the dentists that I talk to, and I show the slide, and I said, Jeff, that's exactly why I put it. You know, for example, in the case of an implant or implants, and you're starting, you know, you're starting the planning, and you're going to kind of inform your patient at some point you're going to need to wear a protective guard as the implants heal, and so on and so forth. So this is the reason for the guard. What you're looking at is why you place a guard on a patient, and you know the patient's teeth do need protecting. I mean, look at what's going on, and then it kind of begs to the very question: why are you doing an implant? Okay, what happened to the teeth that you're doing an implant? And one of the explanations is on some patients that this is going on. This is the primary cause of tooth wear. Okay, and then the challenge becomes, if as a dentist, if you're not paying close attention to the airway and you put a guard in this patient, I'm going to talk a few minutes about what impact guards have on your patients. Okay, so I'm going to move on here to the next slide. And this slide here, there's not a lot of research on the interaction between airway and parafunction. There's some, and I didn't put it in this slide for time constraints, but I think it's important to understand that when you place a guard in the patient to protect their dentition, as you should, there are consequences. And sometimes the consequence is, if you have a patient that has an airway that's not fully functional and you put a guard in, the airway is going to change geometry. Okay? Now when you change the geometry of the airway, 3 things will happen. Nothing will happen. The patient will stay the same and their dentition will be protected, and that's good news. Option 2 is, or outcome 2 is rather, that the airway improves. So maybe by virtue of just creating a little vertical, by putting the guard in, it improves the airway. You kind of change the geometry, like I said earlier, and that change in the geometry improves the functionality of the airway. And then the third option is the opposite, where you put a guard in and changing the geometry of the airway worsens the airway. And so we did our own research on that. And this is a little pilot study. We did 14 cases. And what we did is we used the Knox T3, and we sent the patients home with no treatment and then with their night guard. Okay? And this was kind of a study that was done on patients that the dentist had already treated. And then we would partner with the dentist. They had a Knox T3, and they said, you know what, this one patient, I think they might have an airway issue, and I've given them a guard. So I'm going to do 2 nights and see what's actually going on, and find out what's actually happened to the airway when I put the guard in my patient. And what we found is 10 of the 14 cases, the AHI, and that's a number we use to kind of gauge the severity of the airway issue, It stands for apnea and hypopnea index, and that's, those are, frank, obvious events, and we're not even talking about subtle events. These are just AHIs. And 10 out of the 14, but, let's drill down for just a second, and you look at some of these where, like if you look at 14 on here, the patient's AHI was 8 and it went up to 1, so no one would care about that. And there's a couple of them like that. So there's one here, the 6.4 to 7, or 6.4 to 7, that's not a big move. So that's, pretty good. And then you look at others, and the AHI actually went down. Look at number 12. Their AHI was 24, which is moderate, it's halfway to severe. And with the guard, it cut the AHI in half. So that's great news, okay? But look at patient 10. The patient 10, their AHI was 13, and it went up to 26, okay? And so the point here is guards can impact the functionality of the airway. And here's the kind of the twist in all this is, as we've learned, or as I've been talking about, the airway triggers parafunction in a lot of patients. And it's the irony is the very thing that you use to protect your patient's dentition may actually worsen the problem that you're trying to protect it from. Okay? Now that doesn't happen in every patient, and please don't think that I'm saying this is what happens. I'm saying there's a potential, and the potential is, and there's significant consequences. For example, on that patient that had 13 and now their AHI is 26. There's been a couple cases where the patient was, like if you look at patient 9, their AHI is 3.4, which is below diagnostic level for sleep apnea. But with the guard, it's 6.2, and the threshold was crossed. So we can say in patient 10 that the guard actually caused the patient to have sleep apnea, because we went from below 5 to above 5, okay? So I don't want to be foreboding or anything, like that. That's not the point here. The point is, in my opinion, it's important to know what's happening to the airway, especially if the patient that you're helping has any of the other signs or symptoms of an airway issue. For example, their BMI, their neck size, are they sleepy, any of these other conditions. And then on top, we put a guard in, and then we've doubled their AHI. That is a very poor outcome. So, but the good news is it's really easy to figure it out, okay? So, what's the impact? What are we going to do? What's going to happen when we place these guards in, okay? So, your therapy, protective, restorative objective is achieved. Like I said, in some patients, the guard has no impact on the airway, and your goal was to treat something or protect the dentition or whatever the case might be, and you've achieved that. My question to you is, how do you know that you've achieved it? Okay. Point number 2, and this is the possible outcome. The AHI goes up, and what's the most common outcome of a guard that makes that worsens the functionality of the airway, and therefore makes the patient sleep less efficiently? A lot of times these patients aren't compliant with the guard, and I think there's a group of patients that everyone on this call has had where the patient, your patient just won't wear the guard. You say, oh, I like that, it's uncomfortable, and we've heard all the reasons. And one of the reasons, I believe, is that the patient isn't compliant because they don't breathe as well with the guard in. Okay? Outcome number 3, and this is the worst case scenario. Okay? Same situation, the AHI is high or gets worse, you put a guard in, and the patient's compliant, and you've worsened the airway. Okay? So let's talk about that patient that went from 13 AHI. 13, by the way, is mild, and when it went to 26, that's moderate. Okay, so we took that patient from mild, and now unintentionally now they have moderate sleep apnea, and they're compliant. So at this point, whatever it is you're treating them for or protecting them from, has come at the expense of the functionality of the airway. Okay, that has profound implications. Okay, I really don't need to put too fine a point on that one. And then lastly, number 4, the outcome where the therapy protective guard actually improves the airway function. You know, hey, that's great news. I'm treating you for something, and by the way, your airway improves. And that's good for everybody. And that's certainly a possible outcome. And we see that all the time. And my statement to you, and the point of this slide is how do you know? And the motto for my company is called Measure and Know. Okay? I'll just tell you, this is my 2, possibly 3-minute sales pitch. So I'm saying measure and know. And there's 2 devices that I like. One of them I developed. The other one I helped develop. And one is a screener. It's called the Gem Pro. And that's a dental instrument. It's not a medical device. It was designed for dentists, and it measures the oxygen desaturations in your heart rate. It measures parafunction, snoring, and body position. Body position is really important because the airway is, more than anything else, is influenced by the sleeping position of the patient. And if you're trying to improve the airway using an oral appliance, a sleep appliance, if you have to go 70% on your back or 80% sleeping on your back, you might only have to go to 60% on your side. Okay, so for a dentist, it is important because you can use the body position or positional therapy to help you get to where you want to go. And the reason being is we know what the side effects of titrating a sleep appliance are. And when you're putting that much pressure on the mandible, we're opening the door for a number of side effects, teeth migration and TMJD issues and what have you. And if we can treat the patient and not put as much pressure on the mandible, it's less likely to exacerbate some side effects that we have to deal with. So the Gem Pro is a dental screening device. I think of it as an oximeter that does snoring and parafunction and body position. The price is $2,000. And then there's the Knox T3. You've seen some of the slides from that device. That's a medical diagnostic instrument. If you're going to diagnose a patient with that, physicians love this device. And I probably don't need to say that physicians need to diagnose patients, but I need to say it because, we just all need to acknowledge that that's the case. And this device is great because it's ubiquitous in the medical community. And as dentists, and if you're venturing in or already kind of involved with working with physicians, it's great if you have a device that they respect and trust. And the Knox T3 is the most successful home sleep recorder in the medical hospital field. So as a dentist, when you show up at a physician's office and you say, hey, listen, I use the Knox T3. It has this bruxism channel. It helps me kind of manage some of the things that I look at. And in learning about, bruxism and parafunction, it's come to my attention that the patient is likely to have some type of airway problem. I'd like to refer the patient to you to be diagnosed, and they're going to like this device. And it just helps kind of ease the bridge between dentists and physicians. So those are the 2 devices, and that's my sales pitch, and I'm moving on. Okay, let's get back to, let's just take a little bit deeper dive into what this central nervous system response is, because it really, I can't tell you how important it is to be able to measure that. What you're looking at here is 30 seconds of breathing, and when you inspire, that's an up. Okay, so this is inspiration, and you can see at the bottom channel, this is the snore. Okay, so when you snore, that's during inspiration. Okay, so that makes sense. When you inhale, it creates negative pressure, a vacuum, and if there's a vulnerable airway, it's going to start drawing in, and if that section where the airway is vulnerable, if that's where your soft tissue is, you snore. Okay, now there's other areas where you can get resistance, not just at the soft tissue area. But when it's in the soft tissue area, you're in luck because we're going to hear the problem. We call it snoring. When you breathe in and the area of resistance is not at the soft tissue, we get a completely different problem, and that's upper airway resistance. Okay, so an upper airway resistance is something that I believe affects every person on this call, whether you know it or not, because when patients breathe in and you're expecting to get a couple liters of flow or oxygen, air in, and you don't, the body's going to try harder to suck in so you get the amount or volume of air, and when you don't get it, it causes a problem. Okay, and what happens? The body says, oh, there's a problem, and it triggers the CNS response. Okay, so this is kind of the syndrome that we see in patients with upper airway resistance and snoring. Okay, here's an example. Let me explain this slide. And this slide, what we're looking at here is this bottom channel here, that's snoring. That's just those spikes, each one of those spikes is snoring, and then you can see what happens eventually. Okay, I didn't put all the channels in there, but when you look at all the channels on this, it's obvious what happened. But when you see the snoring and then you see this, what's interesting about this and why I show this slide is if you look at the signal, the snore signal after, it worked. The snoring stopped. Okay? So the CNS response worked. That's great news. Okay? Not for the enamel, but for the airway. You know, and if we're setting priorities, you know, not to, you know, be too subtle about it, you know, I'd choose an airway over a clench any day of the week. So in my view, the body did a great job of restoring this patient's airway. All right, so this is something that I like to show. This data is from the Gym Pro, and one of the things that's kind of funny that I thought it was funny is I used to talk about positional bruxism. You know, early on, I used to kind of almost in an antagonizing way say, "Oh yeah, bruxism's positional," and the point was that bruxism's really not positional. Airway triggered parafunction can be in those patients that have positional airway issues. And this is a case of a patient that has that. So the bottom channel where it says the audio, that is the red is when the patient's sleeping on their back, and you can see they snore like crazy. And then look at the parafunction though. It almost looks like a snore channel. It's so linked. And then when the patient goes to the right side, you can see there's no snoring and there's very little. There's really no parafunction, and then they move back to their back, and then you can see where it just goes again. So this is a case where we can clearly say and link the airway to the parafunction because it's positional. And when you see positional bruxism or positional parafunction, as we see here, it's a pretty easy conclusion to draw. Okay. All right. So I'm going to be handing the presentation over to Dr. Spencer Jamison here in just a minute, but I spent a lot of time talking about parafunction and bruxism, so I just want to kind of be clear on what I'm talking about. So in the literature, there's definitions for bruxism. Now in the literature, they did the research in sleep labs, so they have a little bit different term for it, but there's a clench. We know what that is. There's a thing called RMMA, rhythmic masticatory masseter activation. And those are kind of little twitches, but they come in like 3s and 4s, and they're quick and they're not very strong, but they're very linear to bruxism. Okay, and then the third one there is a grind. There's a definition there, and then if there's a malocclusion in there, that just exacerbates the problem. It doesn't cause the problem, in my opinion. Malocclusions aren't really responsible for bruxism, and I'm a little out of my league talking about that. I'll just be honest. But excuse me, I know when a patient has a high tooth, those are the patients that generate the highest or the strongest clenches. Okay, and then there is any tooth contact which we can measure. Okay, so because of these, because this research was done from the medical perspective, there was a very tight criteria, as there needs to be. We defined them and we measured and we looked for we set up their study to look for these specific things. That left off a lot of parafunction. So on top of these definitions that you're looking at, I add to that any tooth contact that we can measure. Okay, and so with that being said, I'm going to go ahead and we're going to have a quick little pause here. We're going to open the meeting up for questions, and at this point, the questions are going to need to come through your chat. So on the right side of your control panel, you should see a little chat feature, and on that chat feature, just type in your question, and we'll, Jamison and I will field your questions, and we'll keep the meeting going that way. I think that's a great idea. Okay. Okay, guys. So I'm going to go ahead and start looking at the chat. So for those of you that are still on the call, to get to questions for us, just go ahead and type in your chat box your question, and in the meantime, Spencer and I will keep the meeting moving along. Jamison, we do have a question here. I actually have a couple. I'll take the first one, and you can take the second one. So the first one is, how do you measure tooth contact? And so in the case of the Knox T3 unit, the home sleep unit that's used in the medical field and for dentists, that has an EMG amp built into it, and we put a lead on the masseter. And then my contribution to the Knox T3 is we went into the research, we defined what the EMG, or what the clench, grind, and mixed events are, and we built the software algorithm to detect that. So that's how we do it with the Knox T3. And we probably did 5,000 or 6,000 studies, and one of the things that people would always ask, or dentists would always ask, is, well, how strong are they? And I could tell you that the higher the amplitude, the stronger the event. So, but I couldn't say it was like, 4,500 pounds per square inch, or whatever the number might be. So with the Gem Pro, what we do is right before the patient takes the screening device home, the little tablet has this animation, and it will say, bite down as hard as you can, and then there's this little LED that goes higher and higher, and the goal is you try to push that LED bar graph as high as you can, and then we measure the strength and call it the maximum waking bite force, and that's measured in microvolts. And then once the patient goes to sleep, we measure the sleeping parafunction against what they can do while they're awake. So let's see, Ronaldo, I think that's your question now. Yeah, and you know how one of the things that we teach when a dentist starts using actually either product is bruxism is not unique in the fact that a lot of times patients will deny having that issue. You might be looking at completely worn teeth, and you say, hey, listen, I can help you out here. Tell me, do you clench or grind? Or no, I don't do it. And when you do a study, and then you show the patient an image of them clenching and grinding, especially when you can say, you remember right before the test, the tablet had you bite down as hard as you can, and you generated 100, and then you go to the sleep, and they're routinely generating 200, 300 microvolts of force. And when you kind of explain that to them, it helps you kind of break through the denial that's associated with all types of sleep disorders, and it's simply your patients aren't trying to be deceptive. They're just basically unaware of it. Yeah. Yep. Stan had a question for you, Jamison, and it's, what suggestions do you have for a patient who gets TMJ or masseter muscle symptoms when using an oral appliance? If there's no other questions, then let me kind of end the session by thanking everyone for showing up and listening, and we appreciate your time. If you have any questions about the presentation I provided or the devices that we talked about, you see my email address there, and my cell phone number, I didn't put it on there, I probably should have, is 951-496-6126, and I'll be sure that goes out to everyone on the email that you'll receive at the end of this. So With that being said, have a good evening. Go out and vote if you haven't done so, and we'll be looking forward to our next webinar with you. Thanks a lot.